Uh, Good morning, everyone. I would first like to thank at the outset the organizers for giving me an opportunity to speak in this August forum in front of my beloved colleagues. Uh, Without much ado, I'll start with my topic for today, which is COVID-19 and respiratory diseases. I'd like to start off with the case that we usually see in our hospital. So this lady, who was a 32-year-old woman who had no comorbidities, addictions, or drug allergies, presented with a short history of fever, cough, and fatigue of 3 days duration. On examination, she was found to be febrile. She was tachycardic with tachypnea, with a very low oxygen saturation of 40% on room air. She was investigated and found to have features of leukocytosis with a neutrophilic predominance, normal coagulation profile, very high D-dimer levels of 80 milligrams per liter, normal serum biochemistry, and uh, elevated inflammatory markers. The X-ray was classical, uh, classically showing features of alveolar opacities, interstitial opacities, which were present in both the lungs, in predominantly in the middle and the lower zones. The patient was suspected to have COVID-19 in view of the ongoing pandemic, and the nasopharyngeal swab, rightly so, turned out to be showing features consistent with a COVID pneumonia. So, in words of Joshua Ledenberg, we live in an evolutionary competition with microbes in the present times. That is the bacteria and the viruses. And there's no guarantee that we will survive. So, coronavirus, that is the SARS coronavirus 2, it belongs to a broad group of coronavirus family. It's a single-stranded RNA. And it is a virus which has a proclivity to affect the respiratory epithelial cells. As of yesterday evening, more than 474 million cases worldwide have been affected with the coronavirus since the last 2 years, since the beginning of this pandemic, and it has resulted in more than 6 million deaths till yesterday evening. When we talk about coronavirus, how do we define that a person has a coronavirus infection? It is when they have features which are consistent with an acute respiratory infection. And if the nucleic acid tests are found to be positive, then the case of coronavirus is confirmed. It's a virus which has a very high transmissibility as opposed to its other counterparts, that is the seasonal flu and the previous coronavirus, which was prevalent 2 decades back. This virus starts having a transmissibility a few days before the onset of symptoms, and it peaks within the first 5 days of the onset of symptoms. According to the World Health Organization, the coronavirus infection can be classified as asymptomatic, mild disease, moderate disease, severe disease, and a critical disease. Severe and critical diseases are those coronavirus infections which are associated with the involvement of vital organs, and it may be associated with a hypoxia if there is the presence of a COVID pneumonia. More often than not, the risk factors which are associated with a poor outcome of coronavirus infection is associated with advanced age, the presence of a male sex, presence of comorbidities involving the cardiac and the respiratory systems, if the person has been a smoker, obese individuals, and certain type of ethnic backgrounds. In severe COVID infections, what we really find is the presence of high D-dimer levels, elevated white cell counts, low lymphocyte counts, and the presence of significantly elevated markers of inflammation in the form of C-reactive protein, lactate dehydrogenase, as well as the high ferritin levels. Now, what exactly happens in patients who have a COVID pneumonia? In the early phase of the COVID pneumonia, what we find is the presence of acute fibrinous organizing pneumonia like pattern. And this pattern is classically identified by the presence of these fibrin plugs, which are present within the alveoli. And more often than not, they may be associated with the presence of hyaline membranes, which are seen lining the these alveolar walls. When the disease becomes severe, the pathological form that it takes is in the form of a diffuse alveolar damage, and that is classically seen by the presence of these cellular debris within the alveoli, the presence of hyaline membranes lining the alveolar walls, and significant congestion of the interstitium, along with the presence of these inflammatory cells within the interstitium. The vessels are also involved in COVID-19 related pneumonia, and this is mainly in the form of the presence of clots within the vessels, and it includes all the types of vessels, right from the small vessels to the large vessels. The main clinical features, as I've already mentioned earlier, would be in the form of COVID-related pneumonia, and COVID-related pneumonia can be mild or moderate or severe. Thankfully, the severe and the critical forms of the illness are seen in less than 5% of the cases. I would like to mention over here that COVID-related infections is a multi-system disease, as we all would be aware by now, and it affects almost all the systems in the body, starting from the cardiovascular system, the neurological system, the renals, endocrines, the GI system, you name it, and those systems can be affected with this infection. So coming to the management, I would stick to the management of the respiratory system over here, but we should not forget to treat the patient as a whole, wherein we have to pay importance to the patient's fluid status, the electrolyte balance, which we see very often is affected in these cases. Not to forget treating these patients with anticoagulants. As you would recall, in my earlier slides, I've mentioned that COVID pneumonia is associated with a significant amount of vessel involvement, predisposing these people to develop clots within their blood vessels. And of course, taking care of the comorbidities which may be associated with a poor outcome if these comorbidities are not taken care of. The respiratory management, for obvious reasons, should be focused on keeping the oxygen levels high. And according to the World Health Organization guidelines, the minimum oxygen target that should be targeted is 90%. So you should try to maintain the oxygen levels above 90%. But according to the Surviving Sepsis Campaign guidelines, they mention that the oxygen should be maintained more than 92%. So with the aim of maintaining a saturation above 92%, either oxygen support can be extended to these patients, or they can be subjected to non-invasive ventilator devices, which includes the continuous positive airway pressure devices, high flow nasal cannula devices, and non-invasive positive pressure ventilation devices. During this pandemic, awake prone positioning became very popular. So we knew that prone positioning was used during the severe ARDS management as a method to improve the oxygenation of the patient. But during this pandemic, it was found that even awake proning, when the person was not actually intubated and put on a ventilator, resulted in improvement of the oxygenation. And this was mainly attributed to the improvement in the shunt when the patient's position was kept in a prone position. Needless to say, the landmark or the whole therapy of COVID-19 would lay a lot of emphasis on treating the virus. So especially if the antivirals are used in the treatment of COVID-19, especially in the early part of the illness, it may result in a significant amount of improvement and in preventing the long-term outcomes, long-term poor outcomes related to COVID-19 infection. So, leading these trials for the treatment of COVID-19, it was the remdesivir, and the main benefit came from the Act 1 trial, which showed that when remdesivir was given and when compared to the placebo, in which more than 1,000 patients were included in this trial, it was found that patients who were treated with remdesivir had an earlier time to recovery compared to the placebo who did not receive remdesivir. And the difference between the two groups was 10 and 15 days. Unfortunately, these findings were not replicated in a larger trial done by the World Health Organization through the Solidarity platform, and in which they found that there was no real benefit of using remdesivir as opposed to the placebo. However, the US FDA went ahead and gave an approval for the use of remdesivir in treatment of patients with COVID-19 related pneumonia, especially those infections which were associated with hypoxia. It's usually used for a duration of 5 days, and in certain cases, this therapy may be extended up to 10 days. Combination of oral protease inhibitors, that is popular by the trade name of Paxlovid. It's a combination of nirmatrelvir along with ritonavir, and this combination is also found to be useful in the treatment of patients of COVID pneumonia, especially in the outpatient settings. The other drug, which is also now approved for use of mild to moderate COVID infections, is molnupiravir. Again, this is a repurposed antiviral agent. Earlier, it was being investigated for its role in the treatment of influenza infections, and later on, it was found that it was also effective in the treatment of mild to moderate COVID infections. Now, besides antivirals, immunomodulators play a very important role in the management of COVID pneumonias, and leading the group would be the corticosteroids. In the corticosteroids, it is dexamethasone, especially in low doses of 6 milligrams given by oral or the IV route, has been found to be useful in preventing the poor outcomes of COVID-related pneumonia. It's usually given for a duration of 7 to 10 days, and it may be associated with adverse effects related to the steroid use. The main benefit of dexamethasone as a savior in the treatment of COVID pneumonia came from this trial, which was a recovery trial published in NEJM, and they found that the dexamethasone was significantly associated with improvement in mortality, especially in patients who were on mechanical ventilator support. The other group of drug in this immunomodulators would be the sotrovimab. It's a neutralizing antibody against the COVID virus, against the SARS coronavirus, and its usage in the early phase of the infection prevents the poor outcomes of COVID pneumonia. In patients of COVID pneumonia who are associated with cytokine storm, in which there is hyperinflammation and which results in a severe lung damage, tocilizumab, which is an interleukin-6 inhibitor, has been found to be extremely useful, especially in reducing the hypoxemia and the features of severe lung damage. Baricitinib is again a drug which is a Janus kinase inhibitor. To put it simply, it's an immunomodulator which also has an antiviral effect. And this drug also, in the various trials, has been found to be useful, especially if it is combined with remdesivir in the early part of the illness. So, coming back to our case, our patient was treated with broad spectrum antibiotics. She was given remdesivir for 5 days, treated with dexamethasone, and because she had a severe hypoxemia requiring a non-invasive ventilator support, she was also treated with tocilizumab. Over a period of time, she showed a remarkable improvement. From a requirement of a BiPAP support, she came down to a situation where her oxygen requirements came down to around 2 liters per minute. But unfortunately, during her hospital stay, she developed a complication in the form of development of bilateral pneumothorax, which was treated with intercostal tube drainage and other supportive measures. And over a period of time, she showed a good improvement in with regards to the resolution of the bilateral pneumothorax. Her CT, unfortunately, after her pneumothorax had resolved, showed the presence of these areas of lung fibrosis. So, which brings me to the next part of my talk, post-COVID-19 sequelae. It's basically the presence of symptoms in a patient with a history of probable or confirmed SARS coronavirus 2 infection, usually 3 months from the onset of COVID-19, with symptoms lasting for more than 2 months and not explained by any alternative diagnosis. For the want of time, I'll just skip these slides. This is the schematic representation of the post-COVID-19 related sequelae, which we see in these people. As you can see over here, besides the respiratory system, it is the other systems which also could be making up for the sequelae of COVID-19 infection in the form of a cardiovascular involvement, in the form of patients having psychological abnormalities in the form of insomnia, anxiety, depression, loss of sense of smell and taste. Uh, and coming back to the respiratory sequelae, it's mainly pulmonary fibrosis that we as chest specialists are worried about, and that is seen in approximately a third of our patients at the end of 3 months of this infection. In one of these good trials, which was published in 2021, it was found that almost 25% of the patients have ground glass opacities in the lungs, and almost 1/5 of these patients have parenchymal bands at the end of 3 months when these people were subjected to a CT scan. The main reasons for COVID-related fibrosis is basically dependent on the age of the patient. So, understandably, advanced age will predispose to poor COVID-related pneumonia outcomes. Severity of the disease, those COVID pneumonias which require an ICU stay, especially usage of mechanical ventilator, would result in lung fibrosis. And the silver lining over here is that in almost 3 to 6 months' time, most of these COVID-related parenchymal changes improve with time. Besides the radiological abnormalities, that is in the form of lung fibrosis, there's an affection of the lung function, and this is mainly in the form of the spirometry abnormalities and reduction in the diffusion lung capacity. In fact, almost half of the patients of COVID-19 infections will have reduced diffusion lung capacity, and more severe the COVID pneumonia, more is the reduction in the diffusion lung capacity. Dyspnea is an important symptom which forms part of the COVID sequelae, and more often than not, it is related to the deconditioning that these patients develop during their stay in the hospital. The radiological sequelae will be mainly in the form of fibrosis, ground glassing, which is a marker of inflammation, and sometimes may have these indeterminate lesions, which are basically in the form of these curvilinear shadows, which basically do not carry any significance. This is the follow-up X-ray of a patient 9 months after she has been treated for the COVID pneumonia. As you can see, there are some changes of lung fibrosis in the lungs bilaterally and reduction of the lung volumes. So I would like to end my talk with these take-home messages. Epidemiology remains the most important part of investigation of these people. Okay, so Uh, I would just like to end my talk by saying that COVID-19 pneumonias, they still form a very important part of our management of respiratory cases in our clinical practice. And a lot of stress has to be given to the proper management and taking care of the post-COVID sequelae. Thank you so much.